You are listening to Pharmacy, IT, and Me, your informatics pharmacist podcast. Hey everyone, this is Tony Down. Welcome to another episode of Pharmacy, IT, and Me. And as with every episode, we start this one stating that the intended audience is everybody. And today we'll be speaking with our special guest, Dr. Kelley Carlstrom, on what her role is in the pharmacy technology and informatics world. So thank you so much for taking some time to be on the podcast, Kelley. How are you doing today?
I'm doing great, Tony. Thanks for having me.
Yeah, of course. I guess for our listeners, for them to get to know you a little bit better, can you start off by just telling them a little bit about yourself?
Sure, yeah. I would describe myself as a multi-passionate pharmacist, and I really am working on inspiring and empowering other pharmacists to think differently, to really actively look for opportunities in our profession, to develop non-traditional roles. You know, our profession has had some bad PR as of late, and I really think there's a lot of great opportunity with pharmacy, and I want to see more of us take risks to advance our profession. But my main specialty area is oncology. And I got there through the traditional residency route. I did 2 years of postgraduate training. I took a clinical specialist position, but my current role is as a clinical informatics liaison, and I'm working on a Cerner PowerChart oncology implementation.
Awesome. That's really cool. So I actually have some experience with Cerner Oncology too. So that's kind of like half of the job duties that I do right now are in Cerner Oncology. And, you know, I really respect anybody who's in that role, like doing it the entire time, because it is very, very difficult. So I wanted to kind of know a little bit more about how you got specifically into that role, because you said you did 2 years of residency, and then now you're doing different projects for Cerner Oncology. Like, how did that start?
Yes, and my residency was in oncology, was not in informatics. So I kind of took a bit of a convoluted route to get to my current role. It really, opportunity kind of hollered and I answered. You know, when I was in clinical practice in bone marrow transplant, I was involved in implementing Beacon. We moved from our paper orders into Epic. And I really got to experience firsthand why pharmacist clinician is vital in that. You know, we're the ones with the keen eye for detail. We look at every order sentence, every order detail, every description for accuracy. But the part that I really liked was having a role in the design of the final product, because people were making this for me. I was going to be one of the clinicians using it. And, you know, as the saying goes, if you're not at the table, you're on the menu. So I really liked being involved in the actual creation of the design. And that was a 2-year process. And even after that, I didn't think I would end up working in informatics. But I had a little more than 2 years ago, I had a recruiter reach out to me through LinkedIn about this role that I'm in today. And I honestly thought I would hear them out and that would be the end of it. But what I realized after learning more about the role and thinking about my career path was that I was really at the top rung of my particular career ladder. And I was only 5 years out of residency, so it was a bit surprising to me. So that's what kind of intrigued me about this role. But I really considered it pretty risky. Like, I had invested all this time in traditional residency. I had taken the typical clinical specialist position, and I was considering leaving patient care. And anybody who's worked with me in practice knows that patient counseling is my all-time favorite thing. So it just seemed ridiculous at the time that I was even considering it. But, you know, I really thought more about it and asked myself, what's the worst thing that could happen? You know, the best thing was that you get this great opportunity, you learn these new skills. The worst thing is, okay, maybe you don't like it. Maybe they don't like the work you do, and you look for another job. So in the end, I decided the risk was worth it, and I took that leap. And 2+ years later, here I am.
Wow, that's really cool. That's really awesome. And, you know, like it kind of reminds me of one of my friends. He's like a research pharmacist now, and he did a 2-year residency. He did oncology as his PGY too. And in his current like research role, he actually does some of the build for the order sets, which is kind of interesting. Yeah, it just seems like, you know, being your clinical expert in like that kind of a specialty kind of just leads you to that path of being able to build things for other people to use.
Yeah, like you can learn those technical skills as you go, but the clinical skills are what a lot of the technical teams don't have, particularly with oncology. It's such a niche area.
Yeah, definitely. So what are your current day-to-day duties now in your current role?
So right now we are implementing, of all things, bone marrow transplant. So when they first reached out to me about this role, they said, hey, BMT's on our list. I'm like, okay, great. I love BMT. So we're finally now doing that. And my role is really as a liaison between the technical team doing that build work and the clinical team who's using the end product. So I use the clinical skills that I've got, particularly as it comes to BMT, but I'm there trying to drive the technical team's design towards that effective solution for the treatment plan. So in bone marrow transplant, that would be the conditioning regimens that we're building. I do a lot of team education. Like I did an in-service for our team when we started bone marrow transplant to kind of give them baseline information, baseline knowledge of the words that they're going to hear. Like, what does day 0 mean? What does conditioning mean? I also do a lot of brainstorming and iterating on the design, which is definitely my favorite part. I mentioned I did like that when I was doing it on the clinician end, but I really like kind of trying to consider what all the possible scenarios are and really drill down, like what's going to work? Who's going to order this? When are they going to interact with it? Who's going to activate it? What's going to happen afterwards? I really like that part. And I make all the templates. So kind of like the spec sheet. I take the clinical aspects of the treatment plan, so the chemotherapy, the pre-medications, everything like that, and put it into a spec sheet so the builders can take that and run.
Awesome. And like your mention about like thinking about all the different possibilities, I'm really curious about how do you determine the best course of action, because there's a lot of, I guess, compromise that needs to be done. Because, from my experience, there's like any kind of technical change, it affects the workflow, and then the workflow needs to be a certain way, which can't be done, on the technical side. And like, how do you get to that end point of like getting to a certain level of everyone's not technically everybody's happy, but everyone's like, okay with it, right? Because you can't get everybody to be happy.
Right. That is such a good question. Yeah. It's a challenge, especially in bone marrow transplant, which is such a difficult kind of unique niche of oncology. And these patients are super complicated. They're in the hospital for 6+ weeks usually. So yeah, we've had a couple months of brainstorming. And I think my biggest piece of advice that I've got is to keep asking questions, because we'll have discussions and say, oh, we can't do that. And I'll say, really, we can't do that, or we shouldn't do that, because I want to know the limitations of the system, because I'm not a Cerner expert. So I'm working with Cerner now, or with Cerner PowerChart. And in my clinical practice, I was with Epic. So when I took this job, I actually knew nothing about Cerner. And I did have to reiterate that during my interview to make sure, like, you all know, I don't know Cerner, right? But I've quickly learned in my 2+ years working with it. But yeah, there's a lot of technical things these EHRs can do, but we need to ask the questions about what can it do? What are the limitations? And how does that fit with the department and the workflow that we're working on? Because, we're dealing with our power plans right now and how they're going to be ordered, and who's going to interact with them before the doctor signs them. And that has to do with what the status of that power plan is and all the little pieces that you have to fit into their workflow. And we don't want to design a technical solution around a bad workflow. So if there's workflow changes that need to happen, then that's a great time to do them. But some departments have good workflows, and we just need to come up with the solutions that are going to fit that. So it's really just an iterative process, which is why I like it so much, because I like asking a lot of questions. I guess that's part of my my preceptor days, is to keep asking my residents and students, why?
Yeah, I mean, that's a really good strategy. So I was curious about, like, when you're determining these different workflows, how much customization do you end up doing? Like, I know that there's a degree of customization that can be done, and then there's like that point where it's too much of the work effort that it's not, I wouldn't say like it's not worth it, but it's more of like it would take too many resources to, get it to what they exactly want. So how much customization do you actually get to do? Like, is there like a kind of like a hard stop for that where you can't cross a line, or like, how do you determine that?
So I think there's not a hard stop. So because I'm not an employee of the hospital where I work, I'm a consultant, a contractor. So I mean, other people tell me when we hit that hard line of what we can and cannot do. But I always ask the question from the clinical side of where's the value in it? So, okay, if we need to customize and we need to pull in resources to build something specific, what is the benefit that the end users are getting? So, one example from a previous part of our project was patients who get high-dose high-dose methotrexate and get leucovorin rescue when their methotrexate levels are too high. And that's always a challenging workflow. It was at my previous clinical job too. And just trying to figure out, okay, how can we help them build this into the system to make it, one, safer for patients, more efficient for the clinical end users that are interacting with these orders? And, what are our options? And we did some extra build around that because there were patient safety pieces that made it more valuable. But it is definitely an ongoing question that we ask probably weekly of, is this type of thing we're talking about worth it? And if it is, then, we can describe it in a well thought out process, like creating an SBAR we've had to do for one part. One thing that we're working on, and really just try to explain what we want to get out of it, where the value is, and why the resources should be needed.
Awesome. So, sometimes people are curious too, like, why would a pharmacist be doing this? And why would a pharmacist be working on the build for these order sets? They are a pharmacist, right? They're supposed to be doing clinical care and things like that. What would you say to that if someone was to ask you that?
I would say there are a lot of clinical questions that come up from the technical teams. And before I got there, they were asking these questions of the clinical end users, which is completely appropriate. These are the people that are going to be using it. But those people have to take care of patients 8 hours a day. So they don't have a lot of time to spend answering the questions from the technical team about, why is this drug supposed to be in this particular fluid? Or what about this infuse rate? We can build it these two ways. Why is one better? Those are questions that are important, and they slow down the build process if they're not answered efficiently. And that's where I bring a lot of value to the team, is I'm quickly accessible. I'm an IM away, a text away, an email away, with small questions like that. But also we've got regular, meetings on the books where we talk about these things. So the builders don't have to wait that long to get answers to their questions, and it makes the whole build team more efficient.
Oh, that's really cool. That's really good that you're really accessible like that, and you have that clinical knowledge, because I think that's part of our challenge too, is that, I wasn't trained in oncology. I was more of like, my role has been always in informatics. So it's always like a challenge. We do have a subject matter expert on the oncology side, but it's sometimes difficult with the budget to not have that person cannot be in that role like so many more hours a week than they're budgeted for. So yeah, it's really great that you bring that value because you have that clinical training in oncology as well. So I was wondering if you had any advice for individuals out there who are, maybe they're currently students right now and they want to get into informatics, or particularly oncology informatics, or maybe someone out there is a pharmacist right now that is an oncology pharmacist and they're kind of like you and they want to get into that role. Do you have any advice for them on how they can navigate their way towards that?
Yeah, I think the first thing I would say is the networking piece. I'm a big proponent of networking, really, for all parts of our profession. I think we don't do a great job. There's still many pharmacists that are not on LinkedIn. LinkedIn's my professional network of choice. I have one of my previous residents from years ago. Her LinkedIn page says she's still a PGY1 5 years later. So we need to be better at networking. We need to interact with recruiters. Recruiters reach out to pharmacists all the time and they get ignored a lot. My policy has been never to ignore a recruiter. I may not be looking, but I'll say, hey, thanks for reaching out. Keep me on your list for the future because I'm not actively looking. That's how I got my job that I'm in today. I answered a recruiter's LinkedIn message. I think being open to all kinds of opportunities. You never know where your career path is going to go. I didn't think I would end up here. So just think about the types of skills you'll learn, the types of people you'll meet at different jobs that you might take, because again, these aren't lifetime careers. You're not necessarily going to stay in this job for your entire professional career. So just be open to what you can learn. Find other colleagues to collaborate with. And, one thing that I'm really trying to push more and get more information out there is about taking career risk, because pharmacists are very risk averse. I'm risk averse in general. I definitely was very risk averse before I took this job. But after I took the leap, I realized it was actually riskier to stay where I was. And we don't take career risks very often. And I think it's because of our kind of professional history and how we have these typical roles that we've been in. But taking risk has really paid off for me. And I think it can for others too.
Awesome. That's really, really good advice. And thank you for sharing that. And, I'm very familiar with like you being really active in the pharmacy community and, just in general. So are there any projects that you're working on right now that you want to share?
Yeah, I am, I really thrive on being a people connector. I love getting people together who have similar interests, similar goals, like in networking groups. I think that's really valuable, whether that's on the phone, video calls, in person. LinkedIn messages are great. LinkedIn comments are great, but I really find a lot of value in getting people talking. And the reason I think it's valuable is because we get to ask other people for advice, like we're chatting about now, get insight into other people's career paths, learn what they've done from their experiences, and really can help our own professional development, but also advance our profession. So I'm working on that in two different ways right now. One is I want to get more pharmacists interested in oncology and help them position themselves for these roles through baseline oncology knowledge, toolkits, networking piece, coaching. And I've recently started a newsletter to introduce oncology opportunities and how to network to find these positions. That's my first way that I'm doing this. And then secondly, I also want to spread the word about these non-traditional oncology roles, like what I'm in, and how to really up-level the practice of the experienced oncology clinician. And, our skills are valuable and we often don't know that. And I didn't know that before I took this position. I really want to help share my experiences in that transition.
Awesome. So is there a way that people can reach you if they had any questions or, if they wanted to check out the newsletter?
Yeah, absolutely. You can connect with me on LinkedIn and I'll send you my email that you can put in the show notes, Tony, but it's Kelley, Kelley at kelleycpharmd.com. And I'll also send you the subscribe link to the newsletter so your listeners can sign up for that.
Great. Thank you for that. And I'll be putting that in our show notes so anyone can, check it out if they're interested. But, to be respectful of your time, I'd like to thank you again for taking some time out of your busy day to be on the show.
Thanks so much, Tony. I really appreciate it.
Awesome. Have a great day. All right. If you guys like this episode, you can subscribe and rate us on iTunes, Stitcher, Google Play, or any of your other favorite podcasting services. You can also follow us on social media on Twitter or Facebook at PharmacyITme or Instagram at Pharmacy Informatics or by emailing me at tony@pharmacyitme.com. Thank you again for listening, and I'll see you on the next episode of Pharmacy ITme. And remember, technology is the tool, patient care is the goal.